Testing one, two, testing one, two.
A good evening, John Bennett. How are you? I am happy to see you.
What are you doing, Abdel?
Hello. How are you?
Good, how you doing?
Uh, I am good. I am happy to see you.
I'm happy to see you too. Hey, don't worry about yesterday's mistake. I make them all the time, almost every day. So don't worry about it. Everybody makes mistakes. Okay, you're a neurosurgery resident, right?
Hi.
Yeah, you. Are you a practicing neurosurgeon or a resident?
Uh, I am part medical student.
You're a
Not
resident, right? Are you a resident?
no. I am medical student.
Oh, okay. A medical student. Wow, you're far advanced. In the last year of medical school?
No. I am part medical student.
Okay. Okay, I'm gonna say a few words and then introduce you to introduce Dr. Sandberg, okay?
Okay. I will introduce you Dr. David Sandberg. Okay.
Okay. Pediatric pediatric neurosurgery tumor
Uh,
specialist. Nick, are you there? A friend of mine's here. Nick, can you hear me, Nick? Well, here's Dr. Sandberg now.
Hi, everyone.
Hello, Dr. Sandberg. Welcome.
hello. How are you?
Hi, Abdul Rahman. Thank you for the invitation. Nice to meet you.
Nice. Uh, I am honored to see you.
It's my honor to be here with you. I want to make sure I can figure out how to share my screen.
Yeah, let's try. We got time. We got 12 minutes.
Okay. I don't see that as an option.
You see a share? Are you laptop, desktop? What do you use?
I'm on my laptop.
Okay, at the bottom, there should be a share button at the bottom of the screen.
I see audio, video, participants, chat, raise hand. Oh, share. Here's share.
Yeah, open up the share. Open that up.
Hello, dear John.
Okay, now you go to your PowerPoint. You go to your PowerPoint.
You can see my screen?
Yeah.
Okay, let me close my email.
You can take us where you want. You can take us to your PowerPoint if you'd like.
Good evening, dear John.
Hey, Nick, how you doing? Welcome.
Okay, I have my PowerPoint. Should I go on play?
Yeah, well, you're going to get off the screen, but let me just show you how to put it full screen. At the bottom right, there are 4 icons. Click one of those icons to make it full screen. Yeah, try every one.
1 second. Let me just go to play.
No, you go to the icon at the bottom right. That's what you go to.
Bottom right of Zoom?
Yeah, on the bottom right, there's 4, where your arrow was. It was there, but now you're going to the upper right, the bottom right, bottom right.
Bottom right, where is Zoom?
Yeah, there's 4 icons at the bottom right.
Okay, downloads, brain and heart. This one? Can you see my screen?
I can't because you have an icon there with Quality Council. Can you get rid of that?
Yeah, I got rid of that.
Yeah, get rid of that. It's still there. Get rid of it.
Okay.
Okay, you see there's 4 icons right where that was.
Yeah.
Try each one of them at the bottom right, There you go.
That's downloads. That shouldn't be anything.
Okay, do the next one then.
Next one is, no, that's not it either.
Do each of those 4.
There's Zoom.
No, not that one.
There's only 2 icons there, and then there's a trash.
No, there's 4 icons, but that's the one you got to go to get the proper setting.
This is my messages. That's not.
Okay, no, it's got to be at the bottom right there. At the bottom right.
The bottom right of the PowerPoint application.
Yeah,
The PowerPoint. Okay.
Yeah.
Okay. Oh, I see.
yeah, there you go. Each
Yeah,
one of
yeah.
those. There you go.
Yes.
Perfect. Okay, you got it. Okay, now I'm going to take you off the screen to introduce you
Okay.
when we're ready, okay? But now you know how to get back on.
Great.
So just,
Should I come out of my PowerPoint?
yes, please.
Should I hit stop share?
Yeah. Yeah, okay, now you're back. We're going to introduce you and then you go to your PowerPoint. Okay,
Okay. And then when I go to the PowerPoint,
you click share and then you go to the PowerPoint. Okay. You want to try it again? Click share. Let's
no,
try it again.
I see it. I'm ready. I'm ready to do it.
Yeah, okay.
I think we're good. Sorry, I'm not the best at technical.
No, it's all right. It's okay. You're doing better than most.
Where are you located?
I'm in Miami Beach.
Oh, look at that.
I
I'm
just,
I'm from Miami. I grew up there.
oh, you're kidding. I love it here.
And Abdul Rahman, how many people do you expect to join this meeting today?
I've heard a lot, there'll be a lot just watching on social media,
Yeah,
like you.
yeah. How's my volume? Is my volume good?
Yeah, the volume's good.
Great.
Yeah, well, I just talked to a Nicaraguan neurosurgeon that saw you in 2012,
Oh boy.
and he told me he speaks Spanish.
Yeah.
Did you
Sure.
get that from Miami or Texas?
Before both of those, I've traveled a lot and I've spoken a lot of Spanish in my home, and
Well, if you speak Spanish in Miami, you can survive. If you just speak English, you're going to have a tough time.
I know I grew up there and I lived there.
Which part? Which part?
I grew up in North Miami Beach, and then I worked at Nicholas Children's. It used to be Miami Children's.
Oh, okay.
That was my first job until 2012.
Okay.
I'm gonna turn my phone on silent.
Yeah, we're going to have to get you to the Spanish section too
Okay,
someday.
sure.
Oh, Nora.
Hi, sir. Hello, sir. Hi,
Hello.
hi, Abdurrahman.
Hello,
Hi, sir.
how are you?
Now, Nora's going to take it. If I have a heart attack, Nora's going to take over.
Uh-huh.
No,
Okay,
no,
Nora.
no. Oh, I'll take over, but may you be safe and you don't have any
No,
heart
I'm
attack.
just joking. I'm just joking. But you're equipped. You're
Yeah.
equipped to. You're equipped to.
Yeah, okay, thank you very much. But it's an honor to be here, and Sir Professor Sandberg, it's an honor to see you. I'm a
My
huge fan
honor.
of your work,
Oh,
and your
thank
book is
you.
your book is excellent, so
Oh,
so
thank you.
fantastic, and basically you have touched a very good point from the aspect of how a neurosurgeon sees things, because many people are not quite aware of how we think, and they usually see us very differently than what you have described. Thank you very much. It's something that resonates with all of us.
Thank you. Where are you, Nora?
I'm currently in Pakistan. I was previously in New York.
Pakistan.
Yeah, exactly. I'm basically from Pakistan.
Wonderful.
I was at Mount Sinai for a
Yeah.
while because yeah, to do my fellowship. That's why. But I'm back.
What was your fellowship in?
My fellowship was in neurosurgical oncology.
Oh,
Actually, I
cool.
work I work as co-chair of the education committee of the CNS joint section for tumors. So
Good for you.
I actually yeah, exactly. So I won a basically international fellowship at the CNS. So I joined Mount Sinai under Professor Isabel Germano and Joshua Battison. Joshua Battison being more cerebrovascular surgeon, but his wife was basically with whom I was supposed to be with. So it was
Great.
great. So thank you.
Wonderful.
Hello, dear Nur Maria. I'm Nicholas from Thessaloniki, Greece. Nice to see you again.
Thank
You
you very
know,
much, Dr. Nicholas.
Nick from Greece.
Yeah.
Nick, your camera's not working?
I don't know. It is not appearing, my camera. I don't know why.
You might have to reboot or put the latest version of Zoom on your
But it
computer.
is no problem. It is a great honor and great pleasure to be all here with all the friends.
Okay.
So John, there's some issue with the link again because many people can join in, and I'm receiving a few issues from various attendees.
Excuse me, Abdel, Dr. Kush is not here yet.
Yeah, yeah.
Do you see her?
But
I don't see her in the panel. Can you get a hold of her, Abdel? You know, Dr. K,
Okay.
or just alert me
you
if she comes in. Anyone, now that we have Nora here, she can you tell who the panelists are, Nora?
well, I think Dr. Khushbu was here yesterday. Abdul Rahman,
Dr. K, let me get her name.
yeah. How are you doing today? Can you guide us who will be in our panel other than us?
Dr. Kushubu, Dr. Kushubu.
Yeah, Dr. Khushbu.
Yeah, are you there, Dr. Kushubu?
Can seem to be here.
Ah, the Dr. Koshobo cannot.
Oh, okay, she can't come.
Oh,
Cannot.
okay. But I don't know. But I've just received a few texts from from the attendees. They say that the link is not working.
Okay.
It is working.
Yeah,
We got
I will
17
share
people
the
on the
link.
panel.
Okay. I will share the
yeah,
link.
yeah. It did work for me. But I think I used the previous link.
It's something wrong with their computer. The link is good.
Yeah, probably.
The link is good, but she may have an old version, or he or she may have an old version, or needs to
Or
reboot,
maybe a Mac.
whatever. But
It's more compatible with with the Windows and Android. Sometimes it creates a few problems with Mac
now,
and
who is
iPhone.
that? Who is that that's having trouble? If you can email me the
Actually, there
contact.
are more than one. There are at least three people who have sent me a text that they are having
Really?
some issues with the link. Yeah,
Really? Well, the
yeah.
link works fine. There's two links there. If one link doesn't
Yeah.
work, try the other. Could you tell them that? There's two links here. I have a backup link. If that does happen, look at the bottom. It has a backup link.
Yeah,
And
I believe so. I believe so. It's working. Other than that, we can actually, share the password and the meeting ID, which can be easily put in the Zoom window to join the meeting. It's also a good way. Many people who are using VPN, they use the password and the meeting ID to get into the meeting. It's another way to get in.
okay, 1 minute.
Sandra, I have seen so many of your book signings and various top meetings around the USA. It's amazing to see how many
Oh,
people
thank
really
you.
appreciate it.
Oh,
Exactly, but
Okay,
it's
here
very
we go. I'm sorry to interrupt. Here we go. 10, 9, 8, 7, 6, 5, 4, 3. Good morning. This is Dr. John Bennett broadcasting from Neurosurgical TV in beautiful Miami. Today we have the pleasure of having David Sandberg, a neuro-oncologist from Anderson and University of Texas. And I'm going to let the originator of this webcast with a new channel. Yeah, the new channel is the Global Neurosurgical Student Council. And we have a medical student, Abdel Rahman Aliter, moderating. Welcome, Abdel.
Welcome to Dr. John Bennett, Dr. Noor Al-Huda, Dr. David Sandberg. It's my great honor to introduce Professor David Sandberg, one of the world's leading pediatric pediatric neurosurgeon. He is the director of pediatric neurosurgery at the University of Texas. And now he will share with us his inspiring lecture entitled Brain and Heart that rhymes and strictures of pediatric and neurosurgery.
Thank you very much, Abdul Rahman. I'm going to share my screen.
Perfect,
Okay.
perfect.
Can you all see my presentation?
Yes, it's perfect.
yeah.
Okay, so I want to begin by thanking the Global Neurosurgical Students Council for inviting me to speak to you. It's a great honor. And I would like to thank Abdul Rahman for the kind introduction and for inviting me. And I would like to thank our additional esteemed panelist, Noor from Pakistan, for her warm welcome as well. And John, it's nice to meet you too. This is really an honor to meet neurosurgical students from around the world. It's so much fun. This is meant to be informal, and I look forward to answering any questions anybody has. So I'm actually recently retired, so your introduction is slightly out of date. That's not your fault. I recently retired from pediatric neurosurgery. I'm going to talk about that at the end of this talk, and I'm going to talk specifically about why I retired. I was previously the director of pediatric neurosurgery at UT Health, Children's Memorial Hermann Hospital, and MD Anderson Cancer Center. I'm now an adjunct professor of pediatric neurosurgery, but I'm no longer practicing. This lecture is about a book I wrote sharing my experiences, and I'm really excited. The book is called Brain and Heart: The Triumphs and Struggles of a Pediatric Neurosurgeon, and I'm really excited to share this with you because this is one of my primary target audiences are students and residents who I hope can learn from my experiences over the past more than 2 decades of practicing as a pediatric neurosurgeon. So, we're busy people. We have lots of surgeries to do. We have clinics. We have research. We have families. Why did I take the time to write a book? And so the first thing was an accumulation of great stories over the years. There are so many amazing things that each of us sees as a student, as a resident, as an attending neurosurgeon, especially. Incredible patient stories. And I thought these need to be shared. So I would intermittently write down notes when I would see something incredible or crazy or weird or out of the ordinary. And I would save those notes in case I wanted to do something with it later. I didn't know that I was going to write a book, but I accumulated story after story that I wanted to share. There are many books that talk about the patient experience, how horrible it is as a patient to have a brain tumor or many other illnesses. There are very few books that actually share honestly what goes on in the mind of the physician when going about the jobs that we do. So we have very hard conversations with families. We tell families, your child has a brain tumor, or your child who was just hit by a car walking across the street is not going to survive, or your child has died. These are terrible and very challenging conversations to have. And when I have those conversations, I choose my words very carefully. And the parents hear the words that I speak, but they don't get to hear what's going through my mind. And I thought it might be helpful to share honestly in many situations what goes through my mind when having the toughest conversations. Helping students to decide whether to become neurosurgeons, to see what is a day in my life like? What was my training like? What types of situations do I need to encounter? What are the difficulties of a job as a neurosurgeon? And helping residents and young neurosurgeons learn from my experiences, maybe so that they don't make the same mistakes I made during my career. And then thinking about my legacy, thinking about what I'm going to leave behind after I'm gone for my children, for my family, for my friends, for my patients. And so I kind of pieced together my whole career into this book. So the target audience is first is families of children with neurosurgical and other conditions. I thought it'd be helpful to allow them into my mind to hear what I'm actually thinking in various circumstances. And then students, like yourselves, college students, medical students, residents, and neurosurgical colleagues. And then anyone interested in an inside view of medical stories, and particularly the doctor-patient relationship. So choosing a title, why did I call it Brain and Heart, the Triumphs and Struggles of a Pediatric Neurosurgeon? When we think of the brain, we think of precision. We think of the amazing functions that the brain does. It allows us to think, to talk, to remember, to walk, to see, to hear. And the functions are very complex through neural pathways. And I think the lay public thinks of precision as well. When we do surgeries, we use very fancy technology to pinpoint small lesions, to do stereotactic biopsies. We use robots. We use frameless stereotaxy. We have fancy computers and high-powered microscopes and frameless stereotaxy. So many toys at our disposal. What the public doesn't know is how imprecise our field actually is. That if you show the same case to 5 neurosurgeons, you might get 5 different opinions. And that so much of what we do is not actually defined by existing medical literature. So we have to use not only our brains, but we have to use our gut and we have to use our heart. We have to have compassion and we have to do what we would do if this child in front of us, if this patient in front of us was our own child. And I also talk about the heart because I talk openly about the heartbreak that is associated with our field. We deal with terrible situations and we have to stomach them ourselves. So that's the title of the book. The first chapter is about the unpredictable outcomes we face. And the lead patient story that I chose was a very straightforward case. And I did that on purpose because even a straightforward case is often not straightforward. And I talk about a patient named Garrett. In every situation, I use patients' names only with their permission, or else it's a pseudonym. But Garrett was a teenager who was on an ATV, a sport utility vehicle, that flipped over. He wasn't wearing a helmet. He hit his head. He was unconscious. He was with friends. They called 911 and they sent an ambulance. And when they got there, he was comatose. They intubated him. They put a breathing tube in. And he was eventually brought to our hospital by a helicopter. And he had this CT scan, which is a very obvious epidural hematoma, which is causing midline shift. And this is a neurosurgical emergency. And I think we would all agree that you would have to have a very good reason not to do surgery to remove this blood clot pressing on the brain. The problem is that when I examined him, he was not exhibiting any signs of brainstem function. There was a delay in getting him to our hospital. His pupils were large and non-reactive. He had no corneal reflex. He had no gag reflex. He had no response to deep, painful stimuli. And I stimulated him over and over again, and he wasn't breathing above the ventilator. In other words, he essentially, on at least a preliminary exam, looked like he was possibly brain dead, right? And we don't operate on brain dead individuals in general. We just can't bring them back to life. But his CT scan didn't look that bad, as you can see. The brain looks pretty good. It's a little darker on the side of the lesion than the other side, but not much. Um, and it looked like such a straightforward case. I pinched him about 4 or 5 times as hard as I could. And the last time I pinched him, he did a little bit of extensor posturing, meaning he was neurologically quite at risk of being devastated, but he was not quite brain dead yet. And then I had an honest conversation with the parents in which I said to them, look, we would ordinarily take this blood clot out, but your son is so close to brain death that I am so worried that he is not going to have a good outcome. He is never going to wake up and be, he may progress to brain death regardless of what we do because he's so close. And if he doesn't, he's very likely not to be the same kid that you've known and loved. And I said that based on my experience of many years of taking care of children with serious traumatic brain injury, with those with that neurologic exam, particularly with fixed dilated pupils, the overwhelming majority have terrible outcomes. They don't wake up to be the kid that their parents knew and loved and raised. They're fed by tubes. They're 24-hour care required. They're in beds. They're not talking or walking, and they're blind. And that's what I was afraid of. And his parents wanted me to try everything, and I allowed myself to be talked into it. But I told them that if he were my son, I would probably just let him pass. I wouldn't do anything. So I took him to the operating room and I took out this blood clot. And you can read the details in the book, but over the following few days, he woke up completely and he eventually walked out of the hospital. And today, he is an absolutely normal 20-something-year-old kid who, has a job. He works at a nuclear power plant. And to his parents, I'm the hero. I saved his life. I took out this blood clot and he recovered. And they feel they can never do enough to repay me. And they bring me gifts every year and gifts for my team. And it's so rewarding. But in truth, his case haunts me because it shows the imprecision of our decisions. And I almost made the wrong decision. I almost gave them, or I did give them, bad advice. I told them that if he were my kid, I would not operate because his neurologic examination is so poor. And I give other examples in the book about how there is so much uncertainty in what we do. And that's what chapter 1 is about. Chapter 2, and I think this is an especially relevant chapter for neurosurgical students and trainees, is what it takes, at least in the United States, but I think it's more similar than different around the world, to become a neurosurgeon. What were the years of training like? What went through my head? What kind of hours did I work? It was a little different back then. It was, these days in the United States, there are restrictions of work hours. Residents are not allowed to work more than 80 hours a week. Sometimes there's an 8-hour leeway, so it's 88 hours a week. I worked more like 110, 120 hours a week. There are only 168 hours in the week. So you can do the math in terms of how much I was sleeping per night. And I absolutely loved my training. It was incredible. I was so fortunate to learn from some of the best mentors. I was a medical student at Johns Hopkins University. The individuals that you see in this slide, Don Long was the chairman of neurosurgery at the time. Henry Brem was an extraordinary mentor. I worked in his laboratory and developed an interest in brain tumor research. Reed Thompson was the chief resident. And I'll always remember the kindness with which Reed treated me. I was at the bottom of the totem pole, just a medical student. And a reminder to all of you, once you become the big, fancy neurosurgical professor, remember what it's like to be a student and be kind to the students that you're working with that are rotating with you. I went on to do my residency training at Weill Cornell Medical Center in New York. These are some of the most important people who trained me. Richard Fraser was the chairman for my first 4 years until he retired. He said something that was a pearl that I kept with me throughout my career that I think was very informative. He said, patients almost always eventually look like their scans. And what that means is that if you have a CT or an MRI scan that looks terrible, right? But the patient looks very good, you better watch that patient like a hawk because that patient is very likely to deteriorate. On the other hand, if you have a patient like Garrett, like the patient that I discussed in the first chapter, of the book in the first story. If that patient has a terrible neurologic exam, but their imaging studies don't look that bad, there may be hope for recovery, and you should, you know, give them a chance if you can. Phil Gutin, my research career was in brain tumors. Phil Gutin was one of the leading brain tumor neurosurgeons in the United States. He was the chairman at Memorial Sloan Kettering Cancer Center. Phil Stieg, a cerebrovascular surgeon, became chairman of our program in the middle of my program. And my single biggest influence was Mark Swadan, who is a pediatric neurosurgeon in New York at my program. And he was such an extraordinary surgeon, an extraordinary human being. I watched the way he operated, the way he taught, the way he was with families and children. And I said, I want to be like that guy when I grew up. And I've spent my career trying to model myself after Mark Swadan. I had the great fortune to spend a few months at the hospital sick children, arguably the most tremendous, neurosurgical program for children in the world, and learned from these giants. Robin Humphreys on the left, Jim Rutka, Jim Drake, Peter Dirks, and Jeff Blount. They treated me like gold, and I encourage all of you to try to travel and not just learn neurosurgery at one institution, because you'll learn different ways of doing things by going to different institutions, and you'll meet different people who are extraordinary and that will enhance your neurosurgical education. I then did my fellowship at Children's Hospital Los Angeles. It was an extraordinarily busy year. I learned from these two outstanding neurosurgeons, Gordon McComb and Mark Krieger. I did about 600 cases that year. I was on call every other night. I rarely left the hospital. It was one of the best years of my life. It was kind of a bridge to neurosurgical practice, and I left feeling battle trained and ready to go as an attending neurosurgeon. So after discussing my training, the next chapter I think is a really important chapter for trainees also. Hearing the unthinkable, helping families process the diagnosis. As a neurosurgical trainee, we get a lot of training in how to do a surgery. We get training in how to examine a patient and see them in clinic. What I received zero training for, none, was how to talk to a family in a difficult situation. The picture that I show you, that I use with the permission of Dennis Maxon, who's the gentleman on the right with the beard, was one of the worst conversations I've ever had. Dennis was the father of Gus, who's the young boy in the orange shirt that you see with the hat and glasses, and his wife Kelly is next to him. Gus was his only child. Gus had a recurrent malignant brain tumor, an ependymoma. He came for one of my research studies. His mother, unfortunately, they both had Li-Fraumeni syndrome. His mother had a malignant sarcoma, and his mother died. And she died a few weeks ago, leaving Dennis only with Gus as his only immediate family member, who was his son and his precious son. And his son, unfortunately, had a recurrent malignant tumor that failed surgery multiple times, radiation therapy, and chemotherapy. And he came from my clinical trial. And when that trial didn't work, there was nothing left to offer. And I had to have a conversation with this dad in which I told him that not only did he just lose his wife several weeks ago, his beloved wife, but he was going to lose his beloved son and be alone in this world. There's no training that I received to have that conversation. So how do you break that to him? How do you deliver that news? And that's something I discuss in detail in the book, and I'm happy to answer questions about what my approach is. I think in general, you have to be brutally honest. You have to tell the truth, and you have to do it with some compassion, and you have to be a good listener. And I can share more details of my thought process on that. Chapter 4, the greatest reward, saving the life of a child. We are so lucky. We are so privileged to be doctors and to be neurosurgeons. We deal with some dramatic circumstances. And when you save the life of a child, or really an adult too, who is loved by his children or her children, etc., I feel as though you're saving the entire world in a certain way. And this is a dramatic story in our book of the most meaningful patient experience I've ever had. Marcella was an 8-year-old girl. I met her in Honduras when I was volunteering. When I was a resident, I was a 4th-year resident, and I spent a month volunteering at the Hospital Escuela in Tegucigalpa, Honduras. And I met this little girl, and she had the tumor that you can see in these MRI images. which they thought in Honduras was a craniopharyngioma, but I knew looking at it, this doesn't look like a craniopharyngioma. This looks like a germinoma that I knew had a 90% long-term survival rate with radiation alone. These days, we would give chemotherapy as well. Back then, it was just radiation, but it was incredibly effective. And I knew that she was going to die in Honduras, that she had no chance of survival at that time. Things may have improved there since then, but she was not going to survive. So I called my mentor, Mark Swadan, the pediatric neurosurgeon who I mentioned previously, on the phone. And I said, I've got this girl. She's got these films. It looks like it's a germinoma. And she presented with diabetes insipidus. She's got a bitemporal hemianopsis. She's been vomiting. She has some hydrocephalus. What should I do with this kid? And he said, let's bring her to the United States. And we went through a whole incredible process that was incredibly difficult to bring her to the United States for treatment. When she came to the United States a few weeks later, unfortunately, there was housing that had been arranged for her that fell through. And so my girlfriend, very kindly, Amy, who's now my wife, allowed me to move in to her apartment. And we gave Marcella's mother and Marcella my apartment, and they stayed there in New York for 3 months. We did an endoscopic biopsy. This is an intraoperative photo with an endoscope. Took a biopsy of the tumor that was obstructing the foramen of Monroe and confirmed the diagnosis of germinoma. She received radiation therapy. The images on top are the tumor before treatment. The tumor completely melted away, and she lived 24 years. We brought her and her sister back to be the flower girls at my wedding, which just showing how much this little girl, this one child, meant to me. She and her sister were the flower girls, and she lived 24 years. Here she is. She went on to become a medical student, and she was training to become a pediatrician. And that's the happy ending that's in the book. Unfortunately, life doesn't always have happy endings. And since the book was published, tragically and incredibly and horribly, Marcella died of a pulmonary embolus. She was having shortness of breath. She was on their medical student rotations. They took her to the hospital. They diagnosed a deep venous thrombosis. They put her on a pulmonary embolus. They put her on anticoagulation, and she seemed to be improving, but then she just died in the middle of the night, and it's one of the greatest tragedies. Chapter 5, Surgical Complications. This is an MRI scan showing an intramedullary spinal cord tumor, and I remember this patient, and I write about him in his book in my book, because I think it's really important to understand as a neurosurgeon. We all think we're going to be the exception. We're going to take such good care of our patients. We're going to study the anatomy. We're going to learn the surgeries. We're going to practice, and we're going to do the right thing every time, and we're not going to have complications. I don't know any neurosurgeons who don't have complications, and the complications really hurt. If you care, which you got to care, they really hurt. So this was a kid who walked into my office. He was having severe pain. He was having difficulties walking, but he walked into my office. And I did surgery on him, and he never walked again. I took off the back of these spinous processes and opened the dura, and this tumor herniated out, and we immediately lost motor evoked potential and somatosensory evoked potential signals. I don't think there was anything I could have done better or differently. We debulked the tumor. It was a glioblastoma multiforme, a malignant tumor that's fatal. But he never walked again after my surgery. And so how do you handle that? How do I handle that emotionally? And what I talk about in the book is that there are different extremes. On the one hand, I could say to myself, you know what? I'm a full professor of neurosurgery. I've been doing this for many years. I've done many operations like this. This has never happened to me before. This would have happened to anybody who did this. And it's not my fault, right? And I could kind of wash my hands of it. I think if you take that attitude, you probably shouldn't be a neurosurgeon at all. You're not worthy of the privilege of being a neurosurgeon. On the other extreme, I could say to myself, oh my God, if Dr. Swadan or Dr. Rutka or someone else had done this surgery, maybe this complication wouldn't have happened. Maybe I shouldn't do these surgeries anymore. Maybe I'm not qualified to do these surgeries. And you let yourself succumb to self-doubt. After all the years of training and largely having very good outcomes in my patients, I don't think that's a good outcome either. So what I think we should land is there's a happy medium between those two extremes, where we think seriously about what went wrong and honestly ask ourselves what could have been done better. We ask ourselves, how is our communication with the family? Could we have communicated better with the family about the risks? We present the case in morbidity and mortality conference, where we have 50 to 100 people in the room hearing about your worst day with video and pictures, proof, and discussing and getting opinions of others. What could have been done better or differently so that perhaps if you have a similar situation, you can do better next time. As I talk about in the book, one of the best neurosurgical conferences I ever went to was a meeting of the American Society, of Pediatric Neurosurgeons, the ASPN, where everyone was asked to present their worst complication. And I was amazed at these amazing professors who showed these cases, and they were so awful. One was more awful than the other, but it was sort of like group therapy, and it was comforting to know that even the very best of us have devastating complications, and we have to come to terms with them. Chapter 6, also, I think very helpful for students, talks about a day in my life. What's it like to wake up in the morning and be a neurosurgeon? Obviously, many days are different from other days. There are some days we're doing surgeries or some we're in clinic. The most difficult days are the ones where I'm pulled in multiple directions, where I have 40 patients in the clinic and there's an emergency surgery that needs to be done. Or I have a whole research meeting planned and an emergency arises that needs to be taken care of. You can't be in two places at once. I talk about the stress and the pressure that we feel. And also, I talk about trying to balance my family life. This is one of my favorite pictures. Our nanny brought our two kids to see me at work one day when they were very young. They don't look like this anymore. They're in high school. But I treasure the moments with my kids. And it is possible to be a good neurosurgeon and also to be a good father or a good mother, to be a family person. I'm proud that I changed as many diapers. My wife is a busy physician herself, and we had a lot of help, which is helpful. But we were very involved and have been very involved in our kids' lives. We have very good relationships with our kids. I changed as many diapers as my wife did when the kids were young. And I think putting in quality time is really important. I have missed things. I have missed, some of my son's soccer matches and things like that. But it is possible to have an absolutely wonderful family life and to have an incredibly busy career as a pediatric neurosurgeon or any other type of neurosurgeon. The next chapter is about all the preventable things that happen to kids. I wanted to educate families about all the ways they can protect themselves. In Houston, Texas, where I live, there are so many gunshot wounds. There are guns that are everywhere, people leave around the house and they don't lock up. And I've seen kids as young as 4 find an unlocked gun and shoot themselves and kill themselves. They don't even know what they're doing, or shoot their siblings. I remember one very young kid under 10 who shot his twin brother. He was completely accidental. He had no knowledge of what he was doing. And his brother is dead, and he's never going to be able to live with himself for having killed his twin brother. It's such a tragedy. Bicycle helmets. Everyone who rides a helmet needs to wear, rides a bicycle needs to wear a helmet. In over 2 decades of neurosurgical practice, I saw many kids killed or have devastating neurological injuries from being hit by a car when they're riding a bike or falling off their bike, hitting their head on the pavement. I never saw a serious head injury in a kid who was wearing a proper fitting helmet. And then I talk about child abuse, non-accidental injury, which is so tragic. The journal article I picture, and I show my sister Michelle, who was a co-author. It was particularly fun to write a paper with my sister. She's a pediatrician in California who has a long-standing interest and expertise in preventing gun violence. The next chapter is about my research. So I devoted a lot of my time to research during my career, and I basically had one idea that I hope was a good one. The idea is to treat malignant brain tumors, specifically medulloblastoma and ependymoma, that occur in the fourth ventricle and often recur in the fourth ventricle around the spine. What they currently get is they get surgery, radiation therapy, and chemotherapy. And when those treatments fail, they often don't survive salvage treatments. And even when they succeed, those treatments are very harmful because You have to get such high drug levels to bypass the blood-brain barrier that the drugs wreak havoc. They cause harm to other organs, and radiation therapy is terrible for the developing brain. So my idea, which I tested in pigs and non-human primates, you see this artist's rendition of the non-human primate work, was to put a catheter in the fourth ventricle and treat directly by infusing drugs and getting high drug concentrations at the site of disease. And nobody had ever done this before. I spent 7 years working on it in animals, and it led to a human clinical trial, which led to multiple human clinical trials. In most patients, the approach failed, but in some patients, tumors shrunk or melted away. I did not cure anybody, but there were kids who would have died within a few months who lived much longer, even a couple of years. So I think there is promise. We just have to find the right drug or drug combination. In the book, though, I focus not just on the research endeavor as a component of my career, but I speak about the patient interactions once again, because I think it's so important. And I'll talk about a little girl named Jocelyn. I use her picture and her name with her parents' permission. You can see she has an asymmetric smile. She has facial weakness because of tumor infiltrating her brainstem. She was so adorable. She had a recurrent ependymoma. And every time I would examine her, I would ask her to walk, and she would do more than I would ask. Instead of walking, she would skip down the hall. And I just loved this little girl who would skip down the hall. She was so cute. And she failed surgery multiple times, radiation therapy and chemotherapy. And my research protocol was their last hope. There was nothing left to offer. And normally, I talk about the patient interaction because I think sometimes we're taught, either on purpose or not on purpose by our teachers, that as a doctor, you have to maintain a certain type of professionalism. You have to maintain a certain distance with your patients. You shouldn't become too emotionally involved because it's not professional. What I would teach is the opposite. I think you should become emotionally involved with your patients, and it means something to them. So this little girl, she had her MRI scan, and normally I'm very efficient. I'm rushing from place to place, but on that morning, this girl had been through so much together with her parents and with me. I couldn't focus. I couldn't concentrate. I kept pulling up the images on the computer screen and refreshing the screen, refresh, 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 over and over again to see whether the treatment that we had given helped her tumor. And when the images finally came up on the screen, her tumor had doubled or tripled in size. It had laughed, literally laughed, at my attempt to treat her tumor. So then I had to go have a conversation with the parents in which I would tell them that there was nothing left to offer and show them the pictures and that this beautiful girl was not going to survive. And my walk over there, normally I move quickly because I'm in a rush, but I walked very slowly because I was so reluctant to have this conversation. And when I started talking to her parents and I showed them the imaging studies, I broke down and I started crying. And I don't mean a little bit. I don't mean like a couple tears down my cheek. I mean, I was bawling uncontrollably. And it was almost as if I was letting the emotions out from taking care of many children over a period of years who died of malignant brain tumors or other horrible tragedies. And I thought at the time, this is terrible what I'm doing. I'm being so unprofessional. Who am I to worry about my own suffering when my suffering is 1,000th of what the parent's suffering is? I mean, this is their daughter, right? But years later, long after she had died, I'd kept in touch with her parents, and I asked them about that interaction. And I asked them, I remember when I told you about Jocelyn's recurrence, and that the treatment didn't work, I started crying. And I wonder what your remembrance of that moment is and what your thoughts are. And they said, of course we remember that. We'll never forget that moment. And we were so grateful to you because we felt like you were really in it with us, like you were part of our family, like you really cared. So that's just a story to keep in mind when you worry about being too professional. Chapter 9, I talk about my experiences in low and middle income countries. Some of you live and work or are students in low and middle income countries. I'm fortunate to live in a country where the very best of neurosurgical care is available to my patients and also my family. If my own children had a neurosurgical condition, they would get the very best care by the very best doctor. But every child is just as worthy as my children. My children are not more deserving than any child who's in an impoverished country around the world. Most of my trips have been focused on neurosurgical teaching. It's the teach a man to fish concept. You don't just go down and do surgeries. You teach the local neurosurgeons how to do surgeries as best as possible with the equipment they have in their own environment. We see things that are tragic. No baby's head should be this big from hydrocephalus. It's a massive head. We see this is called a myelocystocele, a big basketball in the back of a baby, would be treated much earlier in our practice in the United States, but has a great outcome. Again, the focus is on teaching. It's on teaching residents. It's on teaching students in their own environment. So I'm going to talk about something else now. That's kind of the conclusion about the book. I want to share openly my own personal story, which is not in the book, which is why I've retired young, prematurely. I'm 54 years old. I've been practicing neurosurgery for 21 years, and I decided to retire at the end of June. I was recently diagnosed with early onset Parkinson's disease. I started developing a tremor of my right hand. You may be able to see it in the screen. I'm not taking any medicines. I'm doing well otherwise. And interestingly, the tremor was very mild and not affecting surgeries at all because it's a resting tremor. And when my hands are in motion, the tremor goes away. So my surgeries were going perfectly well. But I know the natural history. I saw 3 neurologists. I know the natural history of Parkinson's. And I never wanted to be, sometimes in professional sports, you see athletes that stay on the field long past their prime. And you remember how they were when they were at their best. And you wish that they retired younger. I never wanted to be one of those individuals. I never wanted to be someone who stayed too long. So I thought I would retire at 65, maybe 70. But this Parkinson's has pushed me to retire younger. This is, for those of you who are interested, a nuclear medicine study called a DAT scan. I am the patient in this study, and you can see that the basal ganglia light up more on the right side than on the left. The left basal ganglia corresponds to my right-sided tremor of my right hand. So what I'm doing now is I've been on my book tour, talking about my book, and I'm likely about to start a job. I'm going to have a new career focused on childhood poverty. There's an organization called Covenant House, which helps homeless children in the United States and actually in other countries too. And I'm likely going to be working with them, trying to help kids get jobs who are homeless and impoverished. So that is my story, and that is the story of the book. I hope, it's available to those of you who want to get it around the world. You should be able to get it on Amazon if Amazon is in your countries. And this concludes the lecture, and I am happy to answer any questions that anybody has about any of this, about the book, about my Parkinson's disease, about any aspect of being a pediatric neurosurgeon. And I thank you again for the honor of presenting to your group.
Okay. Thank you so much for your wonderful lecture and for sharing your book with us. I have two questions. Question one. For mention emotional challenges often have pediatric neurosurgeons.
Yeah.
How do you personally balance emotional impact of treating children with life-threatening conditions?
Yeah, thank you for that question. That's such a wonderful and important question. I think you have to know yourself, right? And there are some people who go into neurosurgery who are like, I just could not be a pediatric neurosurgeon. I can't deal with tragedy in children. Those conversations that you have to have with families and to watch a child die, it's so unnatural and it's so tragic and it's not for me. On the other hand, for me, I feel like someone who wants to run towards the fire. Somebody has to have those conversations with those family members. Somebody has to do it. And I think it's so important who does it, and how it's done. I feel very strongly those conversations are remembered by families and parents for the rest of their lives. And I think if even if you're telling a parent that their child has died, if you can do it honestly and with compassion, you can make a huge difference. Some doctors are terrible at those conversations. They beat around the bush. They don't tell the truth, and that leads to confusion. Or others, they say, "Oh, your kid died," and which is so horrible, right? And they have conversations without thinking that this is someone's child. When I had my own children, I learned what goes into raising a child and how much you love a child. And I take my work home with me. And I'm not saying it's not hard for me, but I take great pride in having those conversations. I think it's one of the most important things I've done in my career.
Okay.
Thank you, sir, very much for
Question two. Okay. What advice would you give for international medical students who aspire to enter the field of pediatric and neurosurgery in USA?
I mean, first advice is to dedicate yourself to your profession. It's a calling to read everything you can get your hands on, to participate in every surgery that you can participate in. The other is to accompany doctors when they're having some of these difficult conversations, accompany your professors and see what you think they do well and see what you think could be done better and develop your own style so that you can have these important conversations with families and do them effectively. I would advise trying to learn pediatric neurosurgery at different centers to learn from the best individuals you can in your home country and also try to go abroad. It's hard to do. There are a variety of different scholarships available through different organizations. One of them is, through the American Association of Neurological Surgeons, through the Congress of Neurological Surgeons, through the FIEND, which is the Foundation for International Education in Neurological Surgery. I direct the panel of those who choose for the Bassett Award, which is fellowships to come to the United States for a few months and learn from an outstanding center. So those are a few pieces of advice.
Okay, thank you so much.
Did you have a question, Nora?
No, thank you very much. I really wish to express my deep gratitude for your insightful talk and the way you actually touched a very important point of how actually a neurosurgeon thinks. And there are certain, being a neurosurgeon myself, I have faced several different moments which were, like you have very rightly mentioned, which were very emotional, and they do really have an impact on us and how we actually react to it. But sometimes, the decision was so hard to tell somebody. I even considered that what if I said the patient does not have a survival? What if a patient who is totally normal face an RTA, a road traffic accident, and dies? You cannot guarantee that someone will survive no matter how healthy he or she may be. So it's something very, very it's a big decision to tell and how to tell somebody. So it's you have very nicely mentioned. And sir, I was so happy to see all those mentors you have mentioned. I have the honor of inviting many of them as speakers myself, and
Oh, wonderful.
Bert will. Yes, recently I talked to Professor Mark Soviden. I met him in New York last year. He was a very inspiring figure to me, such a fatherly man, and with a lot of empathy for patient and a lot of affection for his trainees and colleagues. I really appreciated it. So I invited him. He will be delivering a lecture for the CNS, our CNS joint section webinar next month. So
Oh,
it was
terrific.
a great honor. Sir, I also remember, like you have nicely said, that Professor Robert Spitzler once said in his interview that every neurosurgeon has unfortunately a graveyard of patients that he or she visits so often and learn from the complications, because we do have that type of a thing in the back of our mind. But I believe that only those neurosurgeons who do have lot of empathy and a lot of high level of competency do have this type of guilt to revisit any complication or any patient they have lost. But I think it is God's will that prevails. But what we do is, like you have very nicely mentioned, that we know that sometimes it is a very hard decision, but obviously it is our intention that we might be able to help somebody in one way or another. So you have very, very nicely addressed the emotional aspects, the emotional pattern of a neurosurgeon. Thank you so much
No,
for
thank
this
you.
very hard.
I appreciate it so much. I mean, most of the time, as you know, neurosurgery is so much fun because it's so much fun to take out a brain tumor and go out and tell the parents, I took out the whole tumor, it's benign, your child's going to live, everything's going to be okay. Those are magical moments. That's easy. The hard part is telling them about malignant tumors or telling them about tragedies. And also for ourselves emotionally, sometimes we do our very, very best, and the patient is worse after surgery than they were before. And we have to be honest about that, and we have to deal with it. And you have to be honest as a student, can you handle that emotionally if you're going to be a neurosurgeon? You have to be tough mentally and physically to do it. Are there other questions that I can answer from anybody?
Yeah, I have a comment, Doctor. Thank you very much for taking the time. You know, and this has to do with your personal health, not the neurosurgery. You mentioned having to stop operating because obviously Parkinsonism would affect you in the OR. But I had two friends up in Rhode Island one of them has essential hypertension and one of them has Parkinsonism. And
Yeah.
they've been getting really good results with focal ultrasound.
Yeah.
And so I encourage you to look into that. That's all
Yeah,
I have
no,
to say.
I'm well aware of focused ultrasound. My
Okay.
my symptoms are relatively mild, and I'm not even taking any medicines. And focused ultrasound is it's minimally invasive. It's incisionless, but it's not without risk. There are risks associated, and so if I get worse, it's something I'm going to consider.
Thank you.
Other
Em-
questions I can
Yeah,
answer for anybody.
Mbendola, you have a hand raised.
There are a
Hello?
couple of questions in the Q&A. Somebody actually asking you, which case inspired you to choose pediatric neurosurgery between other branches? Well, what actually was your motivation
Yeah, it
behind
wasn't.
choosing?
It wasn't actually a single case or anything. Basically, the way it played out was as a medical student at Johns Hopkins, I became interested in brain tumors because I worked in Henry Brem's lab and worked on brain tumors and became very interested in the problem and particularly local drug delivery. Then, as a resident, you take care of all patients. You take care of adults and children, spine surgery, epilepsy surgery, cerebrovascular, functional, everything. And I just gravitated towards the kids. I love children. Um, I love the cases. The brain tumors were deep tumors in the fourth ventricle, third ventricle, suprasellar region, challenging cases, not as many less challenging superficial tumors. And I liked challenging anatomical cases. And then just having a role model like Dr. Swaydan, I admired his surgical skill and I admired his manner with the patients. And he was someone that I was like, wow, what a meaningful life this guy's having. And I want to be like that guy when I grow up. And so that's where I landed.
It's incredible. So you have amazing role models, which is a very pivotal, play a pivotal role in our career building. So it's really huge, sir. So there is also one question. Sir, what are your views regarding complex spinal dystrophism presenting late and their counseling? It is by Dr. Shivam Sharma.
My opinion regarding complex spinal dysraphism, was that the question?
Exactly. What are your view regarding complex spinal dystrophism presenting late and the counseling of their parents?
Yeah, I mean, in my career, we've been very aggressive at treating, spinal dysraphism at all stages. The open neural tube defects, the myelomeningocele, we in Texas are treating many of them fetoscopically in utero. And so we're trying to give patients the best possible outcome. They have much lower rates of hydrocephalus. Some of them are even continent of urine. I don't know if we're helping from a motor standpoint, but we may be a little bit. So we're treating a lot of them prenatally. And then when patients are born, if they haven't been treated prenatally, we treat the open neural tube defects within 24 hours of birth to try to prevent infection. We start antibiotics, and we're very aggressive about every aspect of it. For the closed neural tube defects, we tend to treat those in a more delayed fashion. We wait till the kids are at least 3 months of age. There's no urgency because they're skin covered and the risks are higher when they're much younger, but we aggressively treat those patients surgically as well. Is there a more specific question that you have about that disease process or anything else?
Probably no, sir. I don't think so. There is anything big, but the patient actually, I think the one who asked this question was from a low middle income country. So there's a huge, this is a very a common question in the developing part of the world because people are especially concerned about how to treat them because many of the cases are actually delayed. So this is basically the question. But we do not have, I think only a few centers around the world are doing fetal surgery.
Right.
Doctors like Dr. Samirul Baba.
Right. In terms of delay for open neural tube defects, we don't have that. I mean, I've seen that a lot in low and middle income countries around the world. There are many logistical challenges to treating patients in a timely fashion that the doctors want to do. That, it's very frustrating to the neurosurgeons in some of these places. I don't have those challenges. Basically, we treat everybody within 24 hours.
And that's the key. And I think this is the third final question here by Dr. Abimbola Sanjobi. He's asking, how can a trainee overcome the fear and esteem issues that come with performing a surgical procedure?
Yeah, that's a great question. I think the good thing about neurosurgical training is when it's done well, and you should hopefully find a center where it's done well, it's a very slow stepwise progression. It's 7 years. It's a long time in the United States to become a neurosurgeon. And you start out very slowly. You make a skin incision, you put in a few sutures at the end of a case, and mostly you watch. Most of what we do is not technically that hard. You obviously, the first thing you do is not to clip an aneurysm, right? So then you learn how to make a burr hole in the skull and you learn how to open the dura and you just become gradually comfortable and you learn how to do things that are easy in superficial areas of the brain that are not eloquent cortex. And you gradually get to more complicated things. And then one day you wake up and you're a competent neurosurgeon. You're never perfect, right? There's still so much to learn throughout your life and throughout your career. I would advise if you have a choice between different residency programs, go to an urban program, not a rural program. Go to a program in a big city that has a lot of trauma, a lot of emergencies, that has a lot of surgeries, because I do think the more you're exposed to, the more battle trained you are, the more comfortable you're going to be when you get out in the world and are asked to do something challenging. And the other thing I would say is you can always ask for help, and you should ask for help. And I talk about that in the book. It's humbling. There were times when I was already a professor and I was in a situation where I was like, you know what? I need some advice or some help. And I could be proud and be like, oh my God, what are people going to think of me if I need help at this stage in my life? No, that's the wrong answer. Do what's best for the patient. Get a colleague to come and help you and get a second pair of eyes on a situation that's difficult.
We have a panelist from Afghanistan that you may be able to help. Ahmad, do you want to come in and ask the question? Unmute, please.
Okay.
Hello. Hello.
Ahmad has a question.
What?
Ahmad has a
Yes.
question.
Okay.
Go ahead, Ahmad.
Salam
Go ahead.
alaikum. Salam. Greeting from Afghanistan.
Greetings.
Thank you.
Hi.
Thanks very much. It's Professor John, and thank you. It was great presentation and great webinar. Thanks also, Dr. Nurul Hada Maria. And
Thank
I
you.
I mentioned that's about in Afghanistan. Unfortunately, we haven't pediatric neurosurgery. and general pediatrician surgeon and the general surgeon doing pediatric neurosurgery in Afghanistan, unfortunately. And we haven't specialist and instrument for pediatric neurosurgery. And we would like to seeking your support and way that's how to help and support Afghanistan. And if I got a chance of France visa, I will be participating the ISPN Congress in France as well. And I have presentation about pediatric neurosurgery in Afghanistan down there. And just I like to say that's our gratitude for you, and you are seeking your support and help for Afghanistan as well, like other low and middle income countries. Thank
Yes.
you very much.
No, thank you. Boy, I wish I could do something to support you. I'm no longer traveling or doing surgery because of my condition. Um, but my hat's off to you for trying to get the best care for the children of your country.
Thank you.
So there was a very interesting thing that came into my mind regarding, like you have said, that how many, the whole thought process of a neurosurgeon, especially the young trainees. The thing is, many of the neurosurgeons, especially those who are underrepresented, like female neurosurgeons and others from the underrepresented group, suffer from the so-called imposter syndrome. And many times it is because of the several, people who are scrutinizing them very badly, or they are having a very hostile environment. So how do you think they should cope with it?
Well, I think, certainly, first of all, I think our field will be better when it's half women and when we have lots of representation from diverse minority and ethnic groups. So, we learn from each other. And women neurosurgeons, I've been told, according to published literature that I haven't seen, or women surgeons in general, have lower complication rates than men. Do you know that?
Oh,
Yes, I do. I
Yeah.
do.
They have lower complication rates and better outcomes. I think the imposter syndrome is something that's felt by almost every neurosurgeon at some point in their career. So I think the most important thing is to know that you're not alone. Just like, you have a complication, you can have self-doubt, and you should examine your complications very carefully and learn from them. But you should know that everybody else has complications too, and that you're not alone, and that you belong as a pediatric neurosurgeon or a neurosurgeon in general. And, I can't give everybody the perfect advice on how to fight the imposter syndrome other than to say that you're not alone. Everybody has it, and it's hard.
You are absolutely right, sir. So I actually received a question from our audience. It is from Dr. Hidayat Safi. He's an Afghan neurosurgeon working in Russia. He wants to ask you, during your early career, did you ever feel so much worried or disappointed that you had second thoughts about neurosurgery, that you decided that I can't do it anymore, I want to leave?
Never, never, ever,
yeah.
ever. I think all of us to choose a career in neurosurgery, we're not afraid of hard work, and we're all maybe a little bit crazy. Um,
Yeah.
I'll tell you the most difficult thing I did as a resident was during my surgical internship. We used to go to a hospital in Jamaica, Queens, in New York, called Jamaica Hospital. And it was a trauma rotation, and it was a very hard rotation. And I remember one day where I worked starting on Saturday morning at 7 o'clock. I worked all day and all night. I slept for 10 minutes. And then I worked all day Sunday, day and night. I slept not at all. So 2 nights, 48 hours, 10 minutes sleep total. And then after that, I had clinic until 3 o'clock. I write about this in the book, actually. And, you know, I felt so exhausted and so just beyond, horrible. that I refused. I was supposed to drive the van as the youngest resident. I was supposed to drive the van from the hospital back to New York City, and I refused to drive the van, which would be perceived as a moment of incredible weakness because the most junior person was supposed to drive the van, but I refused to do it. Um, I don't know. Once I went through that, though, I think I could do anything. In general, I was very happy as a neurosurgeon.
That's amazing. So what, his second question to you is, what was the most challenging case you ever did in your career?
Yeah, I mean, I don't think there's one specific challenging case. I mean, I think I've had some, my career has been focused on recurrent brain tumors. So I've operated on a lot of brain tumors in children where other neurosurgeons have said it's not possible to do surgery anymore, where it's very stuck to the brain stem, needs a far lateral approach, stuck to the basilar artery, things like that. Those are some of the challenging cases. There's no one individual case that was hard. I mean, I think some of the large, deep tumors like pineal tumors when there's bleeding can be a great challenge. Craniopharyngiomas can be very hard. Um, so the tumor cases have been the most challenging because of my practice was seeing a lot of patients who others said there's nothing to be done.
That's great, and that's very fulfilling. Basically, I believe that it's basically when we join neurosurgery, we have a lot of challenges in our mind. So it's very fulfilling to have this very wonderful experience of doing these things in a very best manner. Sometimes, obviously, it is not 100% right, so it's still very fulfilling. So thank you very much.
Thank you.
Okay, Abdel,
Okay.
Doctor.
you want to
Hello.
close it up, Abdel?
Hello, doctor.
Oh, okay,
Hello.
I'm sorry. Go ahead.
Yeah.
Hello.
No,
Hello.
no.
Hello.
I want to ask 2 questions, please.
Where are you
For
from?
from Jordan.
Oh, wonderful.
Yeah. I'm actually U.S. citizen, but live in Jordan. Medical, actually medical student,
Terrific.
but very interested in neurosurgery. So I want to ask you 2 questions, please.
Yes.
Firstly, I'm very sorry to hear that you have Parkinson's disease, but also um, I'm believing that no,
Yes, I'm here. I'm listening.
but I believe you are someone who can live with this event and save the life of this patient, Dr. David.
Yeah.
Yeah,
Well, listen, I could continue doing neurosurgery, but I made the decision not to. Um, and I'm going to choose to serve in other ways.
yeah,
And that is I'm happy. I'm doing fine emotionally.
yeah,
It's unfortunate to, I think one of the reasons I wanted to share this with you is first just to share in the interest of honesty and tell you where I'm at and what I'm doing. But the other is for everybody to know, not just for our patients, but for ourselves, life throws us curveballs, you know? And I actually feel quite lucky. I feel gratitude. I'm grateful that this happened in my 50s, not my 30s or 40s. I'm grateful that, Parkinson's is a condition that I can live a long time. I don't have a glioblastoma multiforme. I'm not saying goodbye to my children or my wife, or my parents, or my sisters or my friends. Um, there's so much to be grateful for,
yeah.
and I'm going to be able to contribute in other ways.
Okay, doctor, I have the first question. What is your feeling when you want to do an operation for a tumor that it's adjacent to eloquent cortex or eloquent structure and brain? What is your feeling?
Yeah, you have to. I think that my feeling is that I'm anxious more than I am if it's not stuck to eloquent brain. But with experience, you have to set your goals very carefully. Is your goal to remove the entire tumor regardless of the damage it's going to cause the patient? Usually not. We use adjuncts, neuromonitoring. We do awake craniotomies when we need to. We do everything possible to preserve neurological function. And then we're left with very difficult situations. An example, one of the most challenging tumors we treat is ependymoma, which is often stuck to the brainstem. I've never seen a child cured except on the first operation. If you don't get the tumor out the first time, the entire time, that child is likely to die. But if that tumor is stuck to the brainstem and you try to take that little bit that's stuck to the brainstem off, you could really hurt a patient, giving them cranial neuropathies, swallowing difficulties, facial weakness, other things. And so the decisions are very, very difficult. And what to do, it depends upon your level of experience and surgical judgment. But, certainly there's more anxiety when the cases are involving children more than adults. And there's more anxiety when the cases involve eloquent cortex for sure.
Okay, Abdel, do you want to wrap it up? Go ahead.
Yeah.
Okay.
Go ahead, Abdel.
Okay. Thank you very much.
It's my pleasure. I wish all of you the very best of luck in your neurosurgical careers. You are in for some wonderful adventures. We are so privileged to have the opportunity to take care of patients and do surgeries. And it's a wonderful career. It's going to get better and better over the course of your careers. And I wish all of you the very best.
Very good. Now, we'll be inviting you to speak to the Spanish neurosurgeons in Spanish
I can't speak Spanish.
about your book.
I'd be happy to.
Excellent. We'll get in touch.
Thank you.
Okay, thank you,
Very much.
everyone. Thank you, Abdel. Thank you,
Bye, everybody.
Noah.
Bye, everybody.
Thank you very much. It was an honor to be here. Thank you very much.
It's my honor. Thank you.